So let's talk about something that maybe is straightforward, where you do have ovarian vein reflux and the plan is just to embolize. And then maybe after that, we'll walk through what the difference would be if you were planning on embolizing as well as stenting on the same day. Can you walk through that procedure, what the patient might expect, and also just how you perform those?
Yeah, what I tell the patient is it's going to be an outpatient. I think this is pretty standard outpatient procedure, some sedation. They probably need it more for anxiety care than actual pain, as we all know, and that they'll stay for an hour or so until the sedation's all over and they'll leave, and the procedure might take an hour and a half or something like that, and that they kind of get back to their usual activity and they'll have a little bit of discomfort that nonsteroidals generally can take care of over the subsequent few days, and that we would want them to come back and continue to follow with us to let us know how we've done and to have an open dialogue about any concerns they might have after the procedure. In terms of the steps on the day of the procedure, I think different people use different approaches to how to get into the veins and treat. I think increasingly the right internal jugular vein is being used, and that's what our main, if not only, approach is. Unless we're convinced that the patient's going to need only a stent, in which case either a high femoral or some people will even use a saphenous origin to the left venous system can be used. I think if you have really good imaging that shows that the lesion is simply a non-thrombotic lesion and it doesn't involve a long extent or any of the external iliac vein, you could use a common femoral vein approach ipsilateral to the side of the problem. In Europe, interestingly, a lot of reflux disease is treated by an arm access, usually a brachial, but could be a basilic vein access as well. It's harder to put IVUS catheters in because of the length. It's going to be harder to stent, if at all possible, to stent from the arm or do IVUS. But just keep in mind that things may change as tools change, and maybe we'll be going from the arm more. And then from there, it really depends on what we think is the main problem, and we'll go from there. If there's some uncertainty about the venous system of the iliac vein, we might go right to an iliac vein venogram and prove that. One of my colleagues, now you mentioned him earlier, actually, Dr. Meisner, who's gotten very active in this area and is a great resource, actually does a balloon occlusion left internal iliac vein injection next after an external iliac vein injection. And he thinks that helps him understand the flow patterns a bit. We need to recognize it's not just what's big and the direction of flow, but also what the pattern of flow and how fast the flow is in different directions that can give insight. But generally, we'll do the iliac vein interrogation only in situations where we're really thinking that the iliac vein is potentially the main problem. Otherwise, we'll go right to the left renal vein and do a left renal venogram, make sure that the left renal vein is flowing well, that there's no significant evidence of obstruction. And in the straightforward cases where there's no concern, particularly when the pre-procedure imaging makes us feel more confident with that, selective left ovarian vein injection from somewhere above the left sacral ala, so you could see the multiple trunks that might exist in patients that fill the venous plexus. And we can get into more details after that, but as part of the venographic workup, I do think at some point, whether at the beginning or at the end, you also interrogate other potential connections to the pelvic venous reservoir, being the right ovarian vein and both internal iliac veins, even if the pre-procedural imaging doesn't suggest that there was right ovarian vein reflux.